Hello, everyone, and welcome to our webinar, the State-Based Cancer Advocacy from the National Coalition for Cancer Survivorship. I'm Shelley Fold-Nasso, CEO of NCCS, and thank you very much for joining us, and we are thrilled to have Peggy Johnson, Executive Director and Chief Operating Officer of Wichita Medical Research and Education Foundation and co-chair of the Kansas Cancer Partnership, joining us. I've had the pleasure of knowing Peggy for many years now and working with her. She's an incredible advocate, and some of you joined us in June at our Cancer Policy and Advocacy Team Symposium here in the D.C. area. And Peggy joined us to talk about state-based advocacy and getting involved in your state cancer plan and cancer partnerships. And everybody loved her presentation, and she did a great job explaining the issues and the ways to get involved. So we decided to invite her back to share her experience and message a little bit more broadly to the people who weren't able to join us for the symposium in June. So thank you all for joining us, and thank you, Peggy, and I'm going to turn it over to you now, Peggy.
Okay, thank you. Thank you to Shelley for the kind words. We have known each other for a long time, and our time together is always good, and we hopefully have been able to accomplish a lot. I also want to thank Lindsay and Kelsey for the invitation to talk today and their help getting the program started. So the objectives for this presentation are to, one, define what comprehensive cancer control is, and that would be highlighting the burden of cancer priorities and public policy work. And then we'll also identify opportunities for collaboration with a focus on state-level priorities, regional cancer coalition opportunities, and public policy objectives. Next slide, please. So all states that receive cancer funding from the Centers for Disease Control for breast and cervical screening, so that's your breast and cervical programs, your cancer registries, or any other cancer funding support, are required to have a comprehensive cancer control program. So today, that's all 50 states, several territories, and a number of tribes. In Kansas, all of those programs are funded under one grant with a different funding line for each one of our programs. These cancer programs vary from state to state by how they are organized, implemented, and to extent funded, because some do receive state funding. The bottom line is exactly what it sounds like, a plan for comprehensive cancer control within the state. Most state health departments, which is usually where the grant resides, are not well enough funded to address each one of the objectives that they identify in their state plans, and therefore they really rely on their partners for help. National funding for this program has remained level for these programs for the last several years. Next slide. Okay, you're on the slide. Thank you. So comprehensive cancer control aims to reduce the incidence, morbidity, and mortality of cancer to improve the quality of life of cancer patients. So in order to do this, efforts need to engage all levels of the national health system in order to enrich the entire population from the healthy to those who are at most highest risk. Additionally, they need groups that are at risk those risks to be met, including those with family history of cancer and those who have been diagnosed, cured, or are in the final stages of disease. So a little more information, most state plans, and that's the plan that's actually developed by the state and their partners, are either 2 to 5 year plans, and then they re-look at the plan after the 2 to the 5 years, however the plan is set out. The plan will use criteria such as the need, potential impact, and likelihood for success to select and retain any previous objectives. So if they look at their plan after 5 years, they haven't met all of their objectives, they very often will bring they'll bring those objectives that have not been met, put them in the new plan. Each state plan has priority objectives, and they are worked on in different ways, but usually include evidence-based strategies and detailed action plans for each that each guide each work. To do the comprehensive cancer control, it takes bringing together key partners and organizations to form coalitions dedicated to preventing and controlling cancer. So these action plans are actually an outline of the role that individual partners are used and how they leverage the resources from each one of the collaborative efforts. Most, but not all, state plans include policy issues to be addressed by the partners. This will vary from state to state, and so it's very important that you look at your own state plans, see if there are policy issues addressed. Our state plan identified policy issues around tobacco in every update of our plan. Next slide, please. So not all comp cancer plans are organized in the same way. Some comp cancer grants are with the state health department, as I'd mentioned, but not all. Several states have programs that are actually administered through universities. Obviously, the tribe grants are organized and administered through the residing tribes in the state. But not all comp cancer plans have a membership component, but most do, because it's such a big job that state health care department can't do it by themselves. State partnerships and coalitions actually encourage connections, and they foster partnerships among the members and facilitate ways across the state that members and their organizations can actually work together to accomplish what one organization or individuals could not accomplish by themselves. We all know this. In order to get things done, we usually are able to do that faster and more efficiently if we have other partners in the process. It allows the state and the partners to leverage resources to support the coalition work, and it helps to build and sustain a partnership between those member organizations, individuals, and the state health care plan. So we've gone through it. It fosters partnership. We leverage resources. One of the important things that we do is that we actually educate decision makers. We work within our systems to make change. It just is a more efficient way to address all cancers in the state, not focusing on one cancer, but focusing on all cancers. State partnerships really strengthen the population-based data sources that are used for cancer surveillance and long-time evaluation. They also use this data for strategic planning, which is very important. To ensure success, they identify a limited number of priorities. So they really look at the priorities and the needs within their state. And they look at them to decide how they can improve the health of the population. The evaluation of the plan documents really result in the strategic planning and activities for the group, and it helps to leverage the resources. So we're looking at how we work within our healthcare systems. We usually look at the state health department for the technical assistance, so they're the ones that are going to have the website, they're going to be the ones that can access the data, they're going to be the ones that are going to actually be able to help organize the meetings, which is very important. So we always need all that technical support. So in Kansas, our KCP, our Kansas Cancer Partnership, provides an opportunity for all the members, individuals and organizations and coalitions to identify and work on the public policy issues together to have greater impact. So we look at all the burden of cancer, we look at how we can help solve some of those things, and then we additionally look at public policy. I do want to caution you that in many states, the state health department personnel are not allowed to work on policy work. The grants that come from CDC specify what policy efforts that the recipients can and cannot do. The member organizations and individuals then become very, very important because they're the ones that can actually work on those policy issues. Next slide, please. So in setting the state priorities, we hope that they include policy issues. So the priority issues of the plan are actually how they address the burden of cancer in the state. So they're going to look at, are enough women going through the breast and cervical program? Is the incidence rate of colon cancer in your state higher than in other states? If so, how are they going to address that burden? So they look at where the burden of cancer is in the plan, in your state, and they set their plan priorities by looking at those issues. Then after they do that, they will look at policy priority issues that could be achievable. So in Kansas, to give you an example, in Kansas, we have partnered with the coalition, has brought in Tobacco-Free Kansas, which has been an organization within Kansas. They're their own 501c that have addressed the use of tobacco in Kansas for many years, probably at least 15 to 20 years that organization has been around. So we partner with them to help them in addressing their priority issues. Tobacco is probably always going to be one of the top priorities in any state. We have decided to partner with the Tobacco-Free Kansas group to help push those priority issues forward, and especially in policy. So most states are going to have maybe 10 top plan priorities, and then from that you would decide which are going to be your public policy issues. Next slide, please. So I'm going to give you some examples of how we have worked in Kansas. So the first one I'm going to talk about in policy is the big P. So the big P is policy issues that require a legislative initiative or a change in law and will need to be passed by the legislature and hopefully signed by the governor. So that's the big P. So Washington, D.C. is the big P. Your state government is the big P, and then you can have some locally. So in 2010, KCP took up the issue of oral chemotherapy. You now hear that more often is called oral parity. So oral chemotherapies, as you all know, were then just becoming more and more the first line of treatments for a number of cancers. They allow patients to stay at home, often have less side effects, and for a rural state like Kansas, oral treatments allowed patients to stay at home, not have to travel long trips in order to go to their cancer treatment. We found that more people would stay on their treatment if they were allowed to do that. So it was an issue that we believed needed to be addressed. Most plans, most healthcare plans, once you start taking an oral chemotherapy, then they switch you over to the pharmacy or the drug program in your healthcare policy. And a lot of healthcare policies simply didn't cover oral chemotherapies, or they covered them at such a high deductible that people were finding it unreasonable for them to be able to continue with an oral chemotherapy. The one that we used as an example in Kansas was one of the first lines of treatment for brain cancer was actually an oral chemotherapy. Well, the oral chemotherapy was $10,000 a month. If they had gone in for infusion for a treatment that was similar to the oral chemotherapy, it would have been paid for under their medical side of their health insurance. For people in the rural parts of the state, it became, can I do this, can I afford to do this, or can I afford to be away from home? So we took this issue up. We developed a number of issue papers to be sent to our legislators, and then we took on the task of identifying a champion who was actually under the dome that would help us carry the issue forward. Next slide, please. So in doing our work, we also identified physicians and patients who would be available to testify if and when we got a hearing. And then We recruited an oncologist from the KU Cancer Center, so that's our NCI designated cancer center in Kansas. And then we also recruited an oncologist who worked within the rural practice. We needed both voices in the hearing. We then found patients who were agreeable to testify in a hearing. And believe it or not, that is a little more difficult than you might imagine. So we found a brain cancer patient from Northwest rural Kansas who actually had brain cancer and had started on the $10,000 oral chemotherapy, and after 2 months determined that he simply couldn't afford to continue on it. He agreed to testified. And we also found a breast cancer patient who was in Kansas City who didn't have far to travel, but the oral chemotherapy had less side effects. It enabled her to be able to stay at home with her children, and she was very willing to testify too. Then we literally stuffed the room with advocates. It was a very rewarding experience. We found that most of the legislators were very naive about, number one, oral drugs and infusion drugs, the difference on cost, if the cost was covered or it wasn't covered. It was a very interesting hearing. It happened in the House side of our legislature, and we were able to get it passed in the House. We were able to find a champion. It was a senator at the time who was a cancer survivor herself, and her son was a cancer survivor. She became our champion, and to be very honest with you, she did the share of the arm twisting. Next slide, please. So the oral chemotherapy bill actually passed, and it passed the last night of the session. So the House version went straight to the Senate. It went to the Senate floor, and it was passed at about 11:50 at night as the session was coming to a close. It was a very rewarding experience, but I have to tell you, the oncologists and the patients made a huge impact on the legislators in the hearing, and our champion really made a difference. She was the one who was having the side meetings in the Capitol. She was the ones who were calling out the legislators who were holding back. We will always be thankful for her involvement in it. The one thing I want to make sure that you understand is that when you find a champion or champions, you need to thank them. You need to thank them in a way that people will know about it. We now can put it on Facebook. We chose to thank our champion. We gave her a plaque and introduced her and told the crowd what she had done at our local Wichita Race for the Cure, where we had 10,000 participants. She was very appreciative of the acknowledgement, and we wanted to make sure that the public knew what she did. We've done this a couple of times since then on other issues that we have, and you want to make sure that you thank them because you're probably going to want to go to them again. Next slide, please. So my next case I'll go through fairly quickly is small p. So this is public policy that actually doesn't have to be done before the state legislature and usually doesn't have to have the governor's signature. So the small p are actually changing policy that's written in your state regulations. The KU Cancer Center, which as I said is an NCI designated cancer center, was very interested in being able to put more patients on clinical trials. Obviously, that's going to be of importance to all of us. So at the time that we did this, routine costs for being accepted into a clinical trial were not covered by your health insurance. So if you had to go in and have blood tests, if you had to have a CT scan, if you had to have any of those things that would have been routine in a regular office visit with your physician, but not associated with a clinical trial would have been covered. They were not covered by your health insurance in order to get onto a clinical trial. So representatives from the KU Cancer Center and a couple of members of KCP actually started conversations with our state insurance commissioner to build our case on how to get the regs changed. Once the process actually started, it didn't take very long. And what it was doing was stopping the barrier for many who wanted to be on clinical trials, and we all agree with that. So once we had the insurance commissioner's approval, she was able to go in and simply change the regulations on how these things were handled within insurance policies issued in the state of Kansas. The way that this policy and actually oral chemotherapy are handled in the state of Kansas is they pass them and they approve them, and then for the first year, they only cover those improvements, only cover state employees. Then after a year, they come back and an evaluation is made if there has been any cost impact on the state. And for both of these, there was no cost impact, and so it took a year, but after that year, both things were passed. And it's actually a fairly easy way for you to get things done. Now, the thing I have to caution you is that in the state of Kansas, the insurance commissioner is actually an elected office. So that insurance commissioner isn't beholden to anyone except their own office. So when you're looking at doing something of this type, you need to look at how your state is organized. I do know that in a number of states, the state insurance commissioner is actually an appointed office. So you need to look at who has the authority within your state to change those regulations and then figure out how you can go about getting those regulations changed. Next slide, please. So I want to talk just real shortly about regional coalitions. So why would a state plan want to have a regional coalition, and why would you as a cancer advocate be interested in regional coalitions? So regional coalitions can actually have impact on selected priorities within your cancer plan that are more important to your region. So we know that some parts of some states have more of a barrier of getting women into breast and cervical screening than other parts of the state. Regional coalitions then have the ability to go in and look at the regional impact and actually work on that impact. The regional coalitions also give you the opportunity to engage regional policyholders. So if I'm going to do something that's in the region that I'm in Kansas, I'm going to look at who the elected officials are, not only at the state level, who those state legislators are, but I'm going to look at city councilmen, county commissioners, because some of the policies that you may want to get changed may be able to start at the local level. It also helps you connect with the people who may be your next state representatives. Very often, if they work within city and county government, then they decide that they want to work at the state level. So it already makes you acquainted with those people. The other thing is regional coalitions really can help you start working with rural parts of your state. Kansas has a number of states are actually considered frontier states. So if we work with regional coalitions, we can then start working with people within those rural areas and see if we can start making an impact. With the Kansas Cancer Partnership, about 85% of the work of our partnership is actually done by conference call. That way we're allowed to bring those people in the rural communities in, but then they also go out and then form those regional partnerships. We have regional coalitions in 4 different regions in the state of Kansas. Wichita is really the only one that's in a populated area. The other 3 regions are in less populated areas in the state. Next slide, please. The regional coalitions also encourage support for your state plan. It allows you to share what that state plan looks like, and it allows you to gain more support for the state plan. Regional coalitions also help you find who those champions could be on issues that are important in their areas. As I've said before, city and county health issues are often not cancer issues, but they're public health issues. Public health always then will lend itself to cancer issues. So the regional coalitions have, as far as I'm concerned, have really been able to strengthen our state comp cancer group, but it also helps us with public policy. I'll give you two examples of regional things that have happened in Kansas. We passed clean indoor air statewide in 2010. What helped us pass that was that a number of communities in the state of Kansas had already implemented clean indoor air policies within their cities and counties. That helped us gain speed and traction in the state when we wanted to pass clean indoor air. The second thing is that we're taking up this year is T21. So T21 is tobacco 21, where we're trying to increase the age of being able to buy tobacco products from 18 to 21. Again, what's happened in the state of Kansas is right now we have about 18 cities that have passed T21. That gives us what we believe is the traction to then go in and start working with the state legislature to actually get a state law passed. So that really is all I have. I hope I've given you an idea on how you can work with your comp cancer plans. As I said, they're different in every state, which makes them sometimes difficult to look at, but it also makes great opportunities for everyone. If anybody's got any questions, I think we'll answer them at the end. And I want to thank everybody for your attention. Thank you.
Thank you, Peggy. We are so grateful to have you with us today to share your expertise on state-based advocacy around cancer. Peggy did an excellent job of explaining what the comprehensive cancer coalitions are and how they impact policy at the state and local level. So I just wanted to take a few minutes to outline how you all can participate in these efforts in your own states. As a national partner of the CDC's Comprehensive Cancer Control, NCCS has joined several other national organizations that support these state cancer coalitions like Peggy's in developing and sustaining cancer control plans to improve the quality of treatment and quality of life for cancer survivors. Through our cancer policy and advocacy team, we support, train, and empower survivors and caregivers to engage on policy issues that affect cancer care. And the CPAT program provides tools and training that builds upon your personal experiences to become effective advocates to improve cancer care. And we keep our advocates on top of pressing national issues like healthcare reform, and then we call on them to take action when needed. And we're very lucky to have CPAT members in 39 states across the U.S., and the CPAT members, those of you who are listening to this webinar, have already been active in your communities and working to improve cancer care where you live. So we want to support you in those efforts and in the state efforts in addition to the federal policy efforts that we work on. So in order to do that, NCCS is developing a new webpage dedicated to state-based advocacy. And it'll be filled with useful tools, resources, and information on how to get involved in your state's comprehensive cancer coalition so that you can make cancer care better for survivors in your state, similar to the examples that Peggy just gave. So on this slide, there's a screenshot of some of the resources that we're going to have on our new state advocacy webpage that's going to launch later this week. On the webpage, we'll have an overview of the Comprehensive Cancer Control Program, and resources for state advocacy, including our advocacy toolkit and ways you can get involved, and information on each state's cancer coalition. My favorite part of the website that I'm showing here is where you can see the red arrow, and we've used Alabama as an example on this slide, and you use the drop-down menu option there, and you scroll down to your state, and you select it, and then you'll be given resources associated with your state's coalition that will appear below. So that's where we have the red arrow there, and you'll see information for the state coalition's webpage, the state's strategic plan, and the state's legislative calendar. And I think it's also important to note that, like Peggy articulated earlier in her presentation, that if you've seen one cancer coalition, you've seen one state cancer coalition, and they all vary greatly. And so some states like Kansas have extensive strategic plans. They have developed great web pages and ways to get involved, whereas other states are still working on developing their plans and their web pages, and our web page will reflect that. So if your state is missing a web page or missing a piece, it might mean that they don't have theirs up and running yet, although most states at this point do. So just reach out to us if you need that information. And I also think this point speaks to the important opportunity that we're outlining here today about how you can get involved in your state to ensure that these resources and that state plans get up and running and get developed, and they have community partners like you all. And as a national partner, NCCS is here to help states get to the stages where they have comprehensive plans with specific action items. And so we aren't just connecting you to state efforts, we're also committed to supporting you in those efforts at the state level and working with the national partnership to help make sure that states have strong and sustaining cancer coalitions like the one that Peggy is a part of. So with that, I will stop talking now, and I'll turn it over to you all for a Q&A session. So if you have any questions, just type it into the chat box at the top of your screen where you see a list of attendees, and Peggy and our team here at NCCS will do our best to answer your questions.
Hello, this is Kelsey. So I actually happen to be, I think some of you know who have worked with me long enough. I am based in Kansas, so I benefit a lot from Peggy's work. That I brought up to Peggy, and I think she mentioned it when she was talking about the regional opportunities and how I think she said about 85% of the work is done on the phone. But I guess I want to say is I don't live in a rural area, but I live in a state that has a lot of rural area. And just trying not to be discouraged of the space that might be between you and that state house. And then I'm really just echoing what she said. I don't have a question, but I just want to reiterate it because I think it's really important that, city, county, boards, opportunities like that, as much as you could try and get involved there, or if you don't mind making the hike every so often. I've certainly seen advocates who, if it's a quarterly meeting, they'll get in and they'll have that in-person interaction, and that's really valuable. But I don't want to be discouraged of the space. Just try and find a creative way to make it work. And I don't know, Peggy, if you really have any more to say about that, or Shelley or Lindsay, or if anybody who's on the phone, who I've seen you all check in, so I do know where all of you live, but I won't call you out. But if you live in a rural state, and if you do some of this work, maybe not so much at the state house, but more even concentrated locally where you live, I think it'd be good to hear just some more examples. Thank you.
So, Lindsay, this is Peggy. Our state plan is old enough, so I think we're probably between 15 and 20 years old now. Actually, I think we're older than that. We have made an effort to reach out to all areas in Kansas, and I have to give the state health department credit for making sure that we're doing that. But I think they need to look at. I get all of the information from the Nebraska Cancer Group, and they have activities that are even way different than Kansas, and we're very similar states. So I think each state CDC allowed the states to organize in their own way that they knew would be successful in their state. So the examples that I give aren't necessarily what you're going to find in your state, but most states are reaching out and trying very hard to reach out to everyone in their state, whether they're in a population hub or whether they're out in the rural parts of their state. So I think they need to go in and look at their plans, see how they're organized, and I know that not all state plans have membership opportunities, but the majority of them do, and Shelley might know more about that. But I really encourage people. I'm a breast cancer advocate. I have learned so much through working with our Comp Cancer Plan about other types of cancer that I feel I'm a much better advocate today than I would have been if I had not had the experience of working with our partners and other people in other parts of our state.
And Randy, I see your question about coalition work in the Washington state. And so that's a great question, and our webpage will have this information up very shortly. And Washington actually back in 2001 created their Comprehensive Cancer Coalition. It's called Washington Cares. That stands for Community Action, Research, and Evidence-Based Systems, and it's run out of the Department of Health, who's one of their critical stakeholders there. And so I'm glad you asked about that, and once we send out our webpage, definitely check out the resources we have for Washington State, and we can connect you to the coalition in your state. Gilda asked the question of how do we find out what our state needs help with, and would this be in the plan? And Peggy, would you like to take this question?
Sure. I think if you go in, I think almost all state plans are now on their websites. And if you go in, you can actually look at what their priority areas are going to be. And it's so when we were redoing our plan this last time, I went out and downloaded probably 10 different plans from 10 different states, and they were all very interesting. I will tell you that tobacco is almost always one of their top priorities. But it's very interesting to see how they're organized, and they will call out what the top issue in the state is and what the priority is on that issue, whether it's survivorship and making sure that all survivors have survivor plans. I know that's a big issue across the United States now. Those state plans that you will find on the website, they're not all created equal, but they should be able to highlight for you what the priorities are, and they may or may not also include what their policy issues are, which I know is very important to NCCS. So I really encourage you to go look at those plans. It may take you a little while to find them, but they will tell you what their priorities are. And then you should find the priority that's important to you. Contact the state office, whoever holds that plan, whoever's responsible for it, and just say, I'm interested in working on this issue. Can you tell me what I can do? And I guarantee you they're going to say, yes, come join us. I can't imagine that they won't. Does that help?
That's great, Peggy. This is Shelley. I was going to address another question that Matt posed. He said that we mentioned that plans should address preventing cancer, and what are some specific ways that plans accomplish this. So I think prevention is really a priority for a lot of these plans, and you've mentioned tobacco. I think that many of the plans kind of start with tobacco as low-hanging fruit, and there have been a variety of different policies around tobacco that plans have included and advocated for. I think also tanning bed laws are ones that are seen often in some of these plans. And Peggy, what are some other examples of prevention policies or initiatives that you've seen in some of the plans that you've addressed or that you've reviewed?
Well, I can tell you one in Kansas that we've been focused on for a couple of years now is increased numbers in colorectal screening. So that really is an area where we know we can have prevention. You can get a mammogram, but that's not going to prevent the cancer. So if you want to concentrate on prevention, we have to look at those ones that we can prevent. And so Kansas has done, and our state partnership has done, a big push to increase the number of people that are getting their colonoscopies at the right screening age, and simply educating people. So we have a public message that goes out. Sometimes it's on TV, in newspapers. We have posters and whatever. So we don't know how to prevent a lot of our cancers, but the cancers that we do know how to prevent, most of the cancer plans are going to try to address it in some way. And, we know that ACS has got the 80 by 18. You go in, and that's one of the places where we actually partnered with ACS and said, we're going to support what you're doing. And so I think you have to look at those cancers that we know that we can prevent, and how you address those. I would guess that most cancer plans, if there's a way to prevent cancer, that they're trying to address it.
I think also a lot of them address HPV vaccinations and how to increase the rate of vaccination among the target populations as well.
Yes.
And I think some are more are looking at more kind of general wellness, like exercise type of interventions. I don't know if that's not as concrete as some of the tobacco and colorectal and HPV vaccination, but I think some are looking at those kinds of interventions too, making some of the policies to make it easier to bike to work, or better walking paths, or things like that promote general exercise and wellness as a form of prevention as well.
Yes, absolutely. Those and those are also called out in our survivor module, to encourage those activities with survivors, with all cancer survivors. So you're right, there's a variety of ways that they can address it. That would be the public health side of it. So those are things that are actually being addressed a lot in local in local counties and cities. And so that's a place we're actually working with a group here in Wichita, the Health and Wellness Coalition, that promote simply healthy living, and that's part of cancer prevention.
Kelsey, did you have a question?
It's more of kind of a statement, but I'll ask Peggy to chime in. And she brought this up yesterday, and I thought it was a good question for us to think about as NCCS was, where this, as you've heard Peggy describe, this happens very locally, and what can we do to support you? And there's a lot we can do to support you, but I think the best thing to start, over and over again, look at those websites. And, fortunately, I live in a state. I'm an individual member of our KCP, so it affords me to be able to get updates and have my voice heard if I need to. But some states, as we've said, don't have that. But you can see what organizations are involved in this partnership. If you're not already involved with them, which I'm sure many of you are, they probably tend to be more cancer specific, or if it's ACS can. But just they would do a lot of the on the ground supporting you and what you want to do and helping you find your way through. And then we are always, here to help you knock on doors and figure out another way too. I don't want that to get left behind and say you go straight to the partnership, because that might not be within reach. I don't know if anybody else has anything to say about that. I don't think I misrepresented our bandwidth, but I think that's about true.
So, Kelsey, one of the things that I would suggest is when you go into your state cancer plan, that you look at who makes up either the steering committee, who makes up the membership. You'll be able to see, I'm listed as with Wichita Medical Research, but I'm also listed with Susan G. Komen. So if you go in and look at your state plan, and you can see who the executive committee is, who the members are, or whatever, you will probably either, if you're an active cancer advocate in your community, you're probably going to see an organization that you're familiar with that you could contact and say, I'm really interested in helping work on cancer, or you could you might see an individual. And so I really encourage you to look up who makes up those coalitions, who makes up those organizations, clinics, institutions that make up the coalition that makes up your state cancer plan. You should be able to see that on the website, and that will give you a better feeling about who actually is involved in it, is involved in the writing of it, because one way to get involved is to say, I'd like to join one of your work groups and help with rewriting the plan when it's time to do that. Mm-hmm. So I think if you go look at the membership of these different state coalitions, that it will help guide you to who you may want to contact first.
Great. Yes, thank you. So I think we'll go ahead and bring it to a close. Some notes for the future. We're going to do at least 2 more webinars, close out this calendar year. We're going to do one on fear of recurrence, and hope to announce the speaker soon. And we're going to do one after the election and talk about what those results need for cancer survivors, access to treatment. And then there's always a chance of something coming up in Congress or in other federal areas that Shelley and Lindsay might just pop on Facebook Live. So pay attention to our social media, the newsletters that go out. Please feel free to contact any of us in the office. We're always available. Peggy, thank you so much for your time, and you were a pleasure to work with. And this will be recorded, and we will make it available for people to view later. So if you want to pass it around to your friends, to your fellow advocates, that would be great.
Thank you.
Thank you.
Right.
Bye, everyone.
Thank you.
Bye.